So, so we can write letter to the authors that what is the position of plaster immobilization. So we can write them and they will answer your question. So Sheetal and Taral, now this was an eye opener for me. So far we have been following the treatment of Monteggia based on this Waters and Raminsky paper, that if it is short oblique, then you nail it. If it is comminuted, you fix it, make a length stable one. But here, all the type 1 fractures, comminuted or short oblique, so all have been treated conservatively. So that was an eye opener. And Bedo type 3 and 4, certainly they are unstable situation and we have to keep an eye. Sheetal, what is your practice for Monteggias?
It's the same what they are presented in the paper. It's not a whole lot different. We reduce all fractures. In our practice, the patients come to the ED. They don't come to our clinic or the office. So in the ED, no matter what fracture they have, they would get an initial attempt at close reduction. And if and then they follow up in the clinic in 4 to 5 days. And if the reduction is maintained, then we just overwrap them. So when they are reduced, they are put into a sugar tongue splint, sometimes with a posterior slab. And when they come to the clinic, we get an X-ray in the splint. And if the fracture is reduced and the radial head is reduced, then we'll just cast them and see them back in a week. The main thing is to follow them weekly for the first 2 or 3 weeks, because if there is a displacement of the fracture or the radial head starts subluxing, you would be able to catch them early on in the 2 or 3 week time, and then you can take them to the OR. So we don't fix them. The indications for fixing them, if they have an open fracture, if it's an open Monteggia, then we tend to fix them. If they have significant other injuries, or if there's a lot of soft tissue injury, then they are admitted. And if there is a compartment syndrome or issues like that, then it's we'll fix it so that we can manage the soft tissues. But other than that, then the paper also shows that, the problems that you're having is mainly with type 3 and 4, Bedo type 3 and 4. And majority of the fractures that we see are type 1 and 2. If you look at the incidence overall of Monteggias that you see, then, 70% are type 1 and 20% are type 2. So your 3 and 4 are only 10% of your practice. That means majority of the fractures, you would be able to get it reduced and treat it close. The issue is you should not miss the diagnosis, and you should have a close follow-up, because if it displaces later on and you don't have a follow-up, then there is an issue. So as long as you have a good system where you're diagnosing it on time and you're following them every week, then all of these need an attempt at close reduction.
So you immobilize in 90-degree elbow flexion so that the triceps keeps a pull on the proximal fragment. What is your position of immobilization?
Usually around 80 to 90 degrees of flexion and supination for most of the type 1. Like type 2, which are posterior, you might have to just extend it a little bit so they can be pushed a little bit anteriorly, but majority of them are splinted in 90 degrees and supination, neutral rotation to supination to keep the head in.
So meaning that even if it is a comminuted ulnar fracture, looks length unstable on primary X-ray, you would treat it conservatively at the outset and follow up at 1 week to see whether there is loss of reduction?
Yeah, all Monteggias, unless it's an open fracture, all of them get a trial of close treatment in the ED. No matter what type it is or whether it's an equivalent injury, they all get reduction. Then you assess the reduction the next day. We see all the X-rays. If the reduction is not optimal, then we have to do something. That means that either the radial head is not reduced, or if the fracture is significantly angulated even after an attempted reduction, then we have to do something. But at least the first trial of close reduction, everyone gets it. All Monteggia fractures get it.
Yes, Taral, your comments on this paper?
Yeah. So about this paper, one thing I had to say that though, their conclusion is that they recommend conservative treatment, they have treated a significant number of patients with operative management. And there has been no randomization. There are no criteria that these are the patients we will treat operatively and these are the patients we would conserve. It has been probably done on surgeon discretion. It's not been mentioned clearly on the paper. Those patients which were treated operatively, why did they operate? Those which were managed conservatively, why did they conserve? Secondly, like in Sheetal's case, that patient would come to ER and it would be managed by emergency resident, and next day would take a decision whether to operate or not. It doesn't happen in our circumstances. Patient comes to your clinic or to your nursing home, and then you have to tell what you're going to do. What I've observed is in younger children, less than 10 or 11, most of the time you are able to manage with close reduction, even fractures which appear comminuted or unstable. But and this happens because once you reduce the radial head, the radius acts as a strut to maintain ulnar length. So if your plaster, many times we don't even apply plaster, we give a slab, or a double slab for sake of swelling, because you have a paper coming up next which talks about compartment syndrome in Monteggia. So a full plaster or a plaster in hyperflexion is something which which we avoid even in conservative treatment. But a well molding of plaster, a very good ulnar border molding is very, very important when giving plaster. There are some patients which will displace even after giving plaster, though radial head is in position, the ulna would displace, and some of those would require K-wire. So our strategy is to reduce and see if it appears stable ulna wise and radial head wise, then you just go ahead with a slab or a plaster. But if it appears unstable, which happens generally in adolescent patients, then you would have to keep a K-wire or a plate ready to put at the same setting.
Yes.
But
Chinmay,
this is a good paper. It's an
nice.
eye opener,
It's nice paper, yeah.
we would say that it goes contrary to what the Boston group says
Exactly
about management.
And all the patients with Bedo type 1 have been treated conservatively. So yes, Chinmay, what is your question?
Yes, sir. My question for Taral, sir. Sir, they mentioned that on the close reduction, they said that the radial head will be in the place, but there is an angulation on the ulna. So there is any specific criteria they come up that how much of the ulna angulation they conserve? Because some of the literature they suggest in this paper only that 36 degree of ulnar angulation should be managed conservative, or more than that should we go for surgical intervention?
No, I don't think you purposely give ulnar angulation during initial close reduction for acute fractures. We don't do that. We get you get ulnar length and alignment. You don't go for high. Like when you do a chronic Monteggia, you give an angulation, but in acute Monteggia, you don't give an angulation.
What his question is, Taral, that when you see a loss of reduction on post-operative film, how much angulation of ulna is acceptable if ulna is going back into hyperflexion? So what is the degree where you should intervene? If radial head remains in, can we accept the great degrees of loss of reduction? That's what his question is.
You can accept, Sheetal, you can answer.
Because they have tendency to remodel, Sheetal, you're on mute. Can you unmute yourself?
Yeah, how much you can accept is based on the age of the patient. So, younger patients, you can accept more angulation at the fracture, I would say even up to 15 to 20 degrees. If you have patients who are more than 10 years of age, then probably 10 degrees. So it's based on age because the remodeling potential is different. So younger patients, I would say 15 to 20 degrees, as long as the radial head is maintained. If you have doubt, you should get elbow x-rays and not forearm x-rays on these patients, because radial head reduction is more important than the healing of the ulnar fracture. It may heal in a little bit of angulation. That would not cause a big issue, in most of the kids, but radial head subluxation or dislocation would. So it's better to, get elbow x-rays on follow-up and make sure that your radial head is staying in. The ulnar fracture, I'm not too much concerned about it.
Yeah, fine. So let's move on to the next paper. Sukalyan, please share your screen.
So very good morning, and it feels great to be in the midst of a very good session that has been going on, and I'll try to keep the pace. It also feels great to be with two of my mentors, Dr. Taral and Dr. Sheetal with me, and great to have all of you around. So Dr. Maulin has very aptly kept these two papers in tandem, because the last one spoke about the displaced fractures of the ulna in Monteggia fractures, and those authors left out or excluded the ulnar plastic deformations. Okay, and now that is what exactly we are going to discuss in this case. So this paper was published in Journal of Pediatric Orthopedics April 2020, and study is conducted in Cincinnati Children's Hospital. So this is a level 3 therapeutic study, and it is retrospective in nature. So we used to find that many cases of plastic deformation of ulna with radial head dislocations were missed during our clinical practice, and that was the very purpose of study, that we wanted to ascertain the circumstances which led to missing of Monteggia fracture dislocation equivalent, and how to manage these cases. Can we really come up with a protocol in case they come in acute scenario that is less than 6 weeks? In order to accomplish that, we searched the keyword radial head dislocation with or without ulnar shaft fracture that essentially defined Monteggia fracture dislocation in a period of last 10 years in the hospital database. And those patients which suffered frank fracture of the ulnar shaft constituted the control group, and the others which had plastic deformation only had become the study group. We also tried to answer to quite a few questions. We tried to compare those two scenarios of the case and control groups, and we also tried to find out why it was missed at the very first place. We also went ahead to do a subgroup comparison between those cases which required plaster management and those which required operative, and then we tried to find out is there any protocol or algorithm which can solve this issue. So we also tried to find the interval between the presentation and diagnosis and the treatment. And in order to quantify the ulnar displacement or the deformity, we tried to take help of the maximum ulnar deformity and its relative position along the shaft of the ulna. The ideal case scenario, it would be diagnosed in an emergency department where close reduction would be tried, and if it is not successful, the patient would be taken to the operative room. In case it was missed at the initial visit, the patient would follow up in the clinic, and he would be directly taken to the operating room and would be treated first with close reduction, and if it's not successful, then open reduction would be employed. We found this elbow score to be a very versatile outcome measure as it took care of the parental concerns because of the deformity, the pain felt by the patient, range of motion, total range of motion, including pronation, supination, and flexion extension added together, and 5 activities of daily living, whether the patient can do it or not. So the results were quite interesting. We found no differences in demographics and in age in terms of in between those patients which suffered a plastic deformation and those who suffered a frank fracture dislocation. Although there was a slight predilection of the ulnar plastic deformation in slightly younger group. And we also found that as many as 72%, that is 13 out of 18 cases that had plastic deformation of the ulna were missed. And 5 of them were missed in our own institute by the radiographer who dismissed the case as being normal. And the same was seen in the emergency department without the consultation of an orthopedic surgeon and sent home. So 11 of them did well in close reduction, while 7 of them had to undergo operative treatment in various combinations as shown. Also, we did a subgroup comparison and found that the elbow score did not matter whether or not the surgical treatment was accomplished or not, as long as the ulnar deformity and the radial head reduction was taken care of. And also, the extent of ulnar deformity did not matter either in closed or operative groups. What really mattered is the time interval between the injury to the diagnosis, which were significantly longer in operative age groups. We did a regression analysis to find that each day of delayed management led to 12.7 increased likelihood of the patient needing surgery. So in discussion, we discussed tenderness, swelling, restricted range of movement, and patient's fear on palpating the region of the elbow and the forearm were very common findings. And if those things were present, it would be very imperative to analyze the radiographs again and again, We also discussed that existence of an isolated post-traumatic radial head dislocation is really doubtful, because the papers which we included in the discussion had an occult plastic deformation of the ulna which was missed by the authors. In those cases, it would be imperative to rule out Monteggia fracture dislocation equivalent by straight posterior border of the ulna, which is an essential prerequisite to rule it out. And also, we should take the help of radiocapitellar line in order to rule this out. In discussion, we also discuss the same thing, that each day is important, as delay would mean increased likelihood for surgery, and we should always strive for close reduction of the radial head at first, and find a stable reduction. The management protocol would be, we'll address the two issues simultaneously. At first, we would try the close correction of the ulnar bowing, and if it is stable, we would keep it just like that. If it is not stable, then we would place a very thick stainment pin, and if the reduction itself was not possible, then we would up and reduce to an osteotomy and plate it. And on the other hand, we would also try close reduction of the radial head dislocation at first, and if it did not come by close methods, we would open it up, repair the annular ligament, and if possible, if required, we'll also place radiocapitellar pin. We did not venture towards annular ligament reconstruction, as we included in our discussion that it might lead to restriction of pronation. So in conclusion, type 1 Monteggia equivalent has the same demographic features similar to other types, so we can expect it at any age. It is missed in the majority of cases. Its delayed management is more likely to require operative intervention, and excellent results can be achieved in both conservative and surgically managed cases. Limitations: there were 6 surgeons who managed the cases. Of course, they tried to maintain the same protocol. It was a retrospective study, and it is also limited by its limited follow-up. So how it would influence my practice? We grow more intent towards suspecting an occult Monteggia fracture dislocation with very small amount of plastic deformation of the ulna. We also started making the whole team aware, including radiologists and the emergency caregivers, that such an entity exists and we should specifically look for it. We would also try to get stable radial head reduction at all costs, be it conservative or operated. And we don't hesitate to fix the ulna with a stout pennant pin, because a thin caver would not be enough to resist the elastic recoil of the ulnar deformation. And we also are more encouraged towards annular ligament repair, because it has consistently shown a very good KIMS outcome score and not ulnar reconstruction. Thank you.
So very nicely presented the paper, Sukalyan. Thank you. Now, Sheetal, I know that Cincinnati is one of the busiest trauma unit across the world, I would say. And you might have observed this phenomenon of missing Monteggia way back. And still the ED department physicians are missing it. So what message you would like to, because in India, most of us are doing private practice and some of them are running fellowship programs. So what would be the message for the residents and practicing orthopedic surgeon, how not to miss this Monteggia?
Yeah, I think that's the main thing about this paper is trying to examine the patient. You know, when we look back on the ED notes of this patients, you know, in our ED, you know, it's not the same team every time. We have community pediatrician who take call and who are treating these patients. We have emergency physicians taking, you know, rotating through different, satellite and different clinics. So it's not the same staff. So they rely a lot on the X-ray report, you know, which the radiologist would generate. So it's kind of, you know, the responsibility is a mixed responsibility of the ED physician, the radiologist, as well as if they consult orthopedic surgeon. Most of these cases, the orthopedic service was never even consulted. So, you know, when they don't see any fracture on the X-ray, it's easy for them to just sprint and send them, you know, just follow up in the clinic. And so one thing what has changed since we got this, you know, to notice is that now in the template of the X-rays for the elbows as well as for forearm, there is a tab, radiocapitellar line. So they have to comment on it, irrespective of whether they are looking at it or not. So whether they say it's aligned, it's sublux, it's dislocated, they have to make a comment of it. So that has changed. As far as the ED physician, a lot of times they just look at the report and treat the patient, like what fractures they have. They're not examining. If you know, I distinctly remember a couple of patients which I have seen in the clinic that were just with no injuries. When I checked the elbow, the patient, you could see the patient was significantly anxious, and when you press on it, they had pain. It's very difficult to miss it. Not based on X-ray, but just on clinical evaluation, that there is an injury there. A radial head sitting outwards, dislocated. In an acute setting, you cannot miss it if you examine the patient. If you examine the elbow and the child, you would not miss it. So most of these, ED physicians, they are not, I don't think they're doing a good clinical evaluation. There is also another issue that has just come up in the last few months. What happened is now we have the tab of the radiocapitular line. So when they have a Monteggia like type 1, we had other two patients just recently. What happened is that the radiologist made a comment that the radial head is subluxed. It wasn't dislocated completely, but it was subluxed, and you could see that the ulna wasn't straight. So it was a Monteggia type 1. But when the ED physician or a pediatrician sees that the radial head is subluxed, their immediate diagnosis is a nursemaid's elbow, because nursemaid's elbow is a radial head subluxation. And the treatment for nursemaid is just an attempted reduction. They need to feel a click, and then they let the patient go without immobilization. So again, in spite of this, there were two recent patients that were misdiagnosed because they were treated as if they have nursemaids. How do you differentiate is that the nursemaid's elbow does not, even though we call it like they have radial head subluxation, the x-rays are always normal or negative in nursemaids. So when you can see a subluxation on an x-ray, it is by definition a Monteggia. Okay, even if it's not dislocated, if it's subluxed, by definition it's a Monteggia, because you seldom have an isolated radial head dislocation. So even going back to all the literature which had commented on radial head dislocation, you can go back and see that they had both ulna. So it's very difficult to have a isolated radial head dislocation, even a subluxation. So now we are trying to see how we can educate the ED physician not to attempt the maneuver for a nursemaid's elbow and send them out without a splint or a cast, because that's how nursemaid is treated. Once you reduce it, you don't need to immobilize the nursemaid, whereas these patients, they need to be immobilized, otherwise it will sublux again. So now we have another task. We'll have to figure out how we educate the ED physician not to treat it as a nursemaid. So, but it's challenging when you don't have a fracture and you still cannot miss it. It's challenging. So you have to examine the patient and look at elbow x-rays and forearm x-rays both.
So another
One question,
Taral, for you.
Yeah.
So
okay, I'll answer this and ask a question. Okay, no problem.
So let me ask to you, Taral, because sometimes we see the very young children where the radial head is not yet ossified, and there the fellows or residents would make a mistake. How would you draw a radiocapitular line when this radial head is not visible? So Taral, this to enlighten all the fellows and doctors.
Yeah. So radiocapitular line is universal. Whether radial is it ossified or not, it doesn't make a difference. It's along the proximal part of radius. So it would still diagnose a dislocated radial head, even if radial head is not ossified. So it's a universal line. Whatever is the position of the X-ray, AP, lateral, oblique, child is crying, whichever view, this is a universal truth. The line along the proximal radius has to go through the center of the capitulum. What is not universal is the Mubarak's line, because there are a lot of variations in ulnar anatomy. It can be normal, or whenever ulna is bowed, even that can be normal sometimes. So, that's a period of contention. One question I had for Sheetal, when I saw this paper, one question I had was how soon after the injury, a missed Monteggia, you can re-reduce closely. And when I went through the tables, there was an 8-day-old missed Monteggia, you were able to successfully reduce, that was in group 1, that's why. And on the other hand, a day 1-old Monteggia was treated with a nailing and surgery. So how do you decide what is the cutoff line? How do you decide once a Monteggia is missed, whether that will be treated by a close reduction or will require a surgery?
Yeah, usually within a week, if you can see this patient and you need to reduce it in the first week, you're going to be fine with close attempts. So it's a stepwise approach. If you can't get it close, then you have to do something. With bowing, it becomes difficult because you need to have sustained pressure to decrease the bowing of the ulna. And a lot of times, you can leave the bowing the way it is, and the radial head would pop in, and that's it. You just put them in a splint and let it just all heal around. But if the radial head is not reducing, then you have to reduce the bow. And then, if the bow is reduced and as soon as you let it go, it wants to spring back into a bowing position, then I would go with a stout Steinman pin to keep it straight. Like the thing is that flexible nail is not a good option here because it takes, it will keep the ulna bowed. If you use a flexible nail, it would just take the shape of the bowed ulna. So you need to have something stout, and that's why a Steinman pin is what we use. It may be a 3mm pin, and that helps to keep the ulna straight, and that would help the radial head to come in. So in the first week, if you even though these fractures were missed, we were able to pick them up in the first few days because they follow up in the clinic. So the idea is that if we don't follow them, or if they present late, then it's an issue. After the first week, we saw that more patients would need surgical treatment rather than close reduction. So I would say a week is a cutoff. In the first week, if you treat them, you would be able to get it closed most of the time.
And have you seen increased anterior displacement of radial head on follow-up compared to the X-ray in ED, or it has been the same? It's just they have missed it and they could not pick up. Has those radial head?
Yeah, these were missed. These were not, the two patients in this report, I think, that had to undergo re-reduction were the ones that were reduced in the ED and then had loss of reduction. But so even if you do a close reduction in the OR, you still need to see these patients weekly. All right. So if you're doing close treatment of a Monteggia, it is really important because I've seen late subluxation of the radial head. So you have to see them at least once a week for the first 3 weeks, and then it's fine if it stays in. There have also been reports of late subluxation of the radial head. So it's important to see them at long term as well. I would, a lot of these reports are short reports for 3 months or 6 months. I usually see them at least at 6 months to make sure that everything is okay, because I've seen a couple of cases where the radial head with growth would keep on subluxing more. About the radiocapitular line, the radial head, if it's not ossified, it's not an issue. You want to draw the line along the proximal part of the radius, along the radial neck, and the proximal part above the bicipital tuberosity, and not along the shaft. That's one. The second thing is radiocapitular line is not very reliable in kids who are less than 4 years of age, just because the capitulum is not ossified. And the ossification of the capitulum is eccentric. So what would happen is, say, for example, you have a type 2 Monteggia, for example, and the radial head is posteriorly subluxed. Even in a normal patient who is 3 or 4 years of age, when you draw a radiocapitular line, it would appear as if it's going posterior. So in that case, it becomes difficult for you to know whether it's just because the capitulum is not ossified enough posteriorly, that's why it's appearing that it's missing the capitulum, or is it a true subluxation? In that case, an ultrasound or MRI would help, if you're doubtful about it. But it would not happen with a type 1 Monteggia, which is normal, because the eccentric ossification is towards the anterior aspect. So if you're missing, the line is missing anteriorly, then it is truly a Monteggia 1.
Yeah.
But if it's missing posteriorly, you cannot say in a child who is less than 4 or 5 years of age, you have to be a little bit careful about, diagnosing a type 2 Monteggia in those patients. And if doubtful, then you may need to get an MRI or an ultrasound.
Yeah, so for that purpose, I always ask my fellows to take contralateral X-ray in identical position when we have doubt about this radiocapitular line, especially in younger children. So for all general orthopedic colleagues, if you have doubt, do not miss, take full length X-ray. Many a times patient would have pronounced tenderness on the ulna, and if you fail to check the elbow joint, always make a habit to take X-ray of both, including both the elbow as well as wrist. And if in doubt, you take contralateral X-ray, and still it's not resolved, you may opt to get MRI or ultrasound, because missing in Monteggia would lead a bigger intervention rather than a small investigation. Let's move on to the last paper. And Sheetal, those are great points. Now, the same experience, Shalin, please share. Same experience we had last week. The radiocapital line was passing posterior to the capitulum. And the fellow asked, is it a type 2 Bedo? And I said, no, this is, the movement was fine. There was no tenderness. So we just conserved it. But that's a confusion always. Yeah, Shalin, go ahead.
Good morning, everyone.
Morning.
The next paper is Compartment Syndrome in Operatively Managed Pediatric Monteggia Fracture and its Equivalent. It's a level 3 retrospective study published in JPO in September 2020. It's a paper from University of Wisconsin. So acute compartment syndrome is the most feared complication of supracondylar humerus fractures. Recently, both bone forearm fractures and floating elbow fractures have also been implicated for acute compartment syndrome in pediatric population. Monteggia fractures have rarely been implicated. So the authors have observed a high rate of acute compartment syndrome in operatively managed Monteggia fracture and their equivalents. The aim of the study was to find the rate of acute compartment syndrome in Monteggia fractures and their equivalents and compare it to the rate of acute compartment syndrome in type 3 supracondylar fractures, where we usually see this complication, and determine the factors which have the highest risk of developing acute compartment syndrome in these cases. They have considered the 3 A's for recognizing acute compartment syndrome: agitation, anxiety, and increasing analgesic requirements in pediatric population. They have included all the classic Monteggia fractures, and for Monteggia equivalents, they have considered the Rockwood pediatric fractures, and they have considered these 7 equivalents. The isolated radial head dislocation, isolated radial head and neck fractures have also been included in this study. So this study is carried out over a period of 14 years at one tertiary pediatric hospital. 2 to 12 years of age is the inclusion population. Children with Monteggia fractures or Monteggia equivalents were defined according to the criteria in Rockwood, and operatively managed fractures were included in the study. So starting with this study, there are total 59 patients which they could found with Monteggia fractures or Monteggia equivalents over this period, and 230 patients had type 3 supracondylar humerus fractures. So out of the 59 of Monteggia fracture or equivalent, 9 developed acute compartment syndrome, which shows a 15.3% incidence. And out of 230 type 3 supracondylar fractures, 2 developed acute compartment syndrome. So they found that this was highly significant difference between these two populations. Also, the next part of the study was to find out the causative factors which would lead to acute compartment syndrome in these fractures. And they studied a variety of fractures ranging from age. They found that preoperative vascular deficit and radial fixation method with nailing were significant for in which the acute compartment syndrome developed. And there was no significant difference between the population where the acute compartment syndrome did not develop or did develop with their age, sex, the Bardo type, whether the injury was primarily managed at another center, not a tertiary center, and the time of presentation from the emergency department to the OR. However, the preoperative neurological deficit showed a significance of 94%. So they are not included in here, but they are mentioned in the paper that is also an important significant difference between the two groups. So these are the cases where acute compartment syndrome developed after operative fixation. So they have discussed that no other previous studies has reported the rate of acute compartment syndrome in pediatric Monteggia fracture or equivalent. The high rate of acute compartment syndrome in this study might be related to this being the first project to compile these cases at a level 1 pediatric trauma center, and clinicians may have observed acute compartment syndrome in these cases, but in isolated cases, and they might not have compiled this data. So the significant difference they found was the preoperative neurovascular deficit and radial fixation method. They have explained it that the preoperative neurovascular deficit is in concordance with the known understanding of the pathophysiology of acute compartment syndrome. And radial fixation method has previously been mentioned in literature. Blackman in his study found that nailing in both bone forearm fracture was associated with acute compartment syndrome in from range of 2% to 7.5%. So acute compartment syndrome with nailing may be due to manipulation intraoperatively or might be an existing acute compartment syndrome preoperatively. So this was their presentation. However, we found that out of the 59 Monteggia fractures or Monteggia equivalent they showed in this study, 40 of those cases were Monteggia equivalent only, and only 19 cases were actually Monteggia fractures. Out of the 40 cases, 7 of the Monteggia equivalent developed compartment syndrome. And out of the 19 Monteggia fractures, only 2 developed acute compartment syndrome. The percentage of this were 17.5 and 10.5. And there was no significant difference between these two. So these are the 7 cases of Monteggia equivalent which developed compartment syndrome. Of these 3 cases were diagnosed or were suspected to be developing compartment syndrome already pre-operatively. So they showed that they have mentioned that in operatively managed Monteggia fracture, they want to study the rate of acute compartment syndrome. However, these 3 cases, they were already suspecting compartment syndrome pre-operatively, and an intra-op fasciotomy was done. After this case where only pressure measurement intraoperatively was considered as indication for fasciotomy and no clinical criteria were used. They measured the intraoperative pressure and found it to be the delta P to be less than 30, and they intervened with a fasciotomy. And these are the 3 cases where post-intervention intraoperatively they found a significant pressure difference, and preoperatively also there were signs of impending compartment syndrome, and they went on to do fasciotomy. These are the 2 cases in Monteggia fracture where acute compartment syndrome developed. So there were only 2 cases out of the 19 where compartment syndrome developed. Out of this, 1 case there was already preoperative nerve palsy, median nerve palsy, sorry, and it was an open fracture and managed with ulnar rod, and they did a fasciotomy. The other was Monteggia type 3 fracture, which was managed with radiocapital pin and intramedullary rod, and intraoperatively, it was diagnosed with acute compartment syndrome, and fasciotomy was done. So limitations of this study would be sample size from a single center, the retrospective nature of the study, and relatively less number of pure Monteggia fractures. And take home message from the study would be to mindful of compartment syndrome in Monteggia equivalents and Monteggia fractures that need operative management, because most of the cases where where compartment syndrome developed, they have mentioned in their abstract that the development of compartment syndrome might be related to the requirement of rodding in radial rodding for radial neck fractures. However, this might be related to the fracture anatomy itself, being a severe fracture with elbow dislocation or with association of olecranon fracture. So those fractures we should be mindful of for developing compartment syndrome. That's all. Thank you.
So nicely read paper, Shaleen, and I agree with you. And I would inquire with Sheetal and Taral, is this conclusion of the paper is right, that indication of fixation of radius, I mean, if you fix the radius, there is high chance of compartment syndrome. So I don't think there's a nice, rightly written. It should be when there is Monteggia equivalent where radius needs fixation, the injury type is very severe or it's a high velocity injury, and that might itself have compartment syndrome. So that is, Sheetal, what do you think about this paper and the inferences?
Yeah, I kind of, the paper is good, but I have a few other issues with the paper. The first thing is that, the diagnosis of compartment syndrome, I don't think that, there were 8 or 9 patients with Monteggia that they reported, I think 9 here. But if you look at the table that presented the details, if you just look at it, for me, the way to make sure that there is a compartment syndrome is that after you do the fasciotomy, the muscles would bulge out and you cannot close the wound. Okay, if you can close the wound after you do a fasciotomy, for me, it's not a compartment syndrome, okay, because you don't have that much swelling. If you have too much swelling, If you've seen real compartment syndrome, the muscles would just bulge out. You cannot close it. If you close it, you are recreating compartment syndrome. So if you look at the paper, they closed the wound on two of these patients. They closed it primarily. In one patient, they closed it the day after, the first day. And then a couple of patients in 2 days.
Yeah.
When we have treated compartment syndrome that were definite compartment syndromes, usually the first 4 or 5 days, you cannot close the wound. And most of the time you would need a split thickness skin graft to close it. You can kind of gradually bring it closer with a vac and then maybe do a primary closure after a week. That's fine. But to be able to close it the next day, to me, that is not a compartment syndrome. So I doubt that. So they were kind of a little bit more aggressive. And that depends on your experience. If you have had one missed compartment syndrome, you're going to open a 5, which appears to be compartment syndrome. So it depends on their experience, but I'm not convinced that all of these were compartment. Having said that, so even if you assume that all of them had compartment syndrome, the only time that I see that true Monteggia is at a risk is there is only one patient. So one had Monteggia open fracture, which we all know that would be a risk. And the only other one is a Monteggia 3 fracture where the ulnar diaphysis is fractured.
Yeah.
Every other is an equivalent, which is an injury around the elbow. It's a comminuted olecranon fracture with radial neck fracture. And so they're not true Monteggia, they're all Monteggia equivalents. So I agree that when you have injuries around the elbow, that means whether it's supracondylar or comminuted olecranon and radial head dislocation, no matter what, you're not going to be searching for what kind of equivalent lesion is this, because there are so many types of it. The bottom line is if you have comminuted fractures and injuries around the elbow, you have to be careful about compartment syndrome. So to me, when I look at my patients, I'm not trying to classify all of them that this is a Monteggia equivalent injury, and that is why I need to be careful about compartment syndrome. For me, if you have a comminuted elbow injury, then all those patients are at risk, so you have to be careful. So that's my take.
So the question to Sheetal first and then to Taral, how would you make your decision of fasciotomy? Can you reliably measure this compartment pressure, and your decisions are based on those compartment pressure measurement or clinical assessment? So first, Sheetal, you suggest, and then Taral, you answer this question.
It's always a clinical assessment. I don't think that you would rely on the compartment pressure. So if the patient is very anxious and kids who are crying and they're agitated, and if they have increased need for medication, if their injury is concerning, if they have median nerve palsy like one of their patient had it, then yeah, your suspicion should be much higher. It's all clinical. Now, intra-op, you can do when you take the patient to the OR, you can do. I don't know what you guys use for compartment pressure measurement, but it's you can measure the pressures to kind of give you a little bit of an idea. But the decision is mainly clinical. When you're taking the patient to the OR, you're not measuring. We don't measure the pressures when the patient is admitted or in the ED. We only measure it in the OR. So at that time, you already know that the patient has clinical signs of compartment. It is better to err on the side of doing a fasciotomy than not doing a fasciotomy. So when I made this point that I don't think that all of them had compartment syndrome, was not to try and argue against the authors that they should not have done a fasciotomy. I'm just, in retrospect, when you can close the wound, probably they did not have a compartment syndrome. But even then, it is always better to err on the side of doing a fasciotomy rather than sit on a compartment syndrome and let the muscle die. So it's a clinical diagnosis for
I have a wart on my foot, and it is very juicy, and it